My name is Jacqueline Lee. I'm the Director of Quality Improvement in the Neuromedicine area at UF Health. Just so I can get a sense of who you all are, how many of you work in healthcare? Okay, so you're in the right place. We're going to talk about specifically some of our projects that have been motivated and fueled by personal narratives from our patients and caregivers. I'll start by sharing a little bit of my story. I'm actually trained as a research psychologist. I worked in the life story lab of Dr. Susan Bluck, so some of you might know her work. The motivation of that lab is to study the functions of autobiographical memory, so people's self-functions, their social functions, directive functions, and I was studying very lofty goals and things like wisdom and storytelling and what makes a good story. And then I became a patient, and the goal of becoming an academic working in an ivory tower very much shifted. I remember very saliently a moment in, I was a patient in a room, and the entourage of nursing students came in, and then the nurse came in, and then the entourage of residents came in, and then the attending came in. And they were talking, and they were saying, the patient is exhibiting, the patient. And I paused them, and I said, excuse me, are you talking about me? And they said, oh yeah, my name is Jacqueline. And although that's not that, pivotal perhaps in their lives, it was for me. And I was just so astonished, and that was just kind of the tipping point of many other events that I had where I convinced my committee to say, we're studying these virtues. Can I study another virtue? Empathy in healthcare. And so that, I did my dissertation on improving empathy and treatment outcomes in patients. I worked in health outcomes, and here I am now working really on the application of improving empathy and other quality improvement initiatives. So we're going to cover these three topics today: what NICAP is, the area in which I work, why we use narratives in NICAP, and then about two handfuls or so projects that have been motivated by our patients and caregivers' personal narratives. And I apologize, for some reason this is rendering differently, so hopefully you can make it out, and if not, just stop me. So I like to preface, NICAP, I'm not asking you out for a drink. It actually stands for Neuromedicine, Interdisciplinary Clinical and Academic Program. And it includes these three areas at UF Health. The clinical area, so that's both the inpatient and our clinics, all the research efforts, education, and actually my program, specifically the quality improvement area, does all of these things. And our teams are really aligned with neurology and neurosurgery, although we do have some interplay with neuroscience and psychiatry and others. And just to give you a sense, it's quite a lot of patients, 35,000 annually, 3,500 inpatients. We work with about 50 faculty, about 35 residents. That part got cut off. And again, just to kind of root it into the context of who we are and what we do. We do have a specific mission of improving quality and safety of patient care, and that's largely what my team's role is. Of course, the mission of the College of Medicine are these three-part aims: clinical research and education. We have a real focus on the physical environment, so you might have seen that tower that's been being built on a new neuromedicine hospital. And so the leadership, we're very keen on being mindful of the specific needs that neuromedicine patients have. And we have the mission in the NICAP of achieving the perfect patient experience. And this actually was coined by my former mentor, who since has retired, Dr. Dick Lister. And I always give him the attribution of this because it's since been adopted by many of our leaders at UF Health. And I want everyone to know it was Dr. Dick Lister who actually came up with this term. So why narratives? Okay, you know that I'm, of course, motivated through my personal experience working in the life story lab. But why have I convinced, and our other leaders are we using narratives to motivate our work? Sometimes providers, health administrators, others, they're really focused on quantitative data, the quantitative data of their patients and outcome measures, readmission data, all of these things. But I believe that narratives are another form of data. They're qualitative data. And without narratives, really we're trying to motivate and improve healthcare by driving forward by only looking in the rearview mirror. So we need both of that. We need those data, and we do all of our projects use the narratives and that qualitative data, but we triangulate it with that quantitative data, and it informs and it's rooted in meaningful information so that we can create projects that are meaningful and resonate in all of our care teams, and then have this kind of longevity to them. So specifically, I'm going to, Brandon mentioned maybe offering some tools that if you're working in healthcare, what you might use to incorporate narratives in your work. We created a Patient Family Advisory Council. It's known as PFAC in the literature. We did that through a grant that we submitted. It's a modest grant of $25,000. Mostly that was to pay a small honorarium for our PFAC members to attend monthly. We of course also had some administrative and research type costs, print materials and others, and then the food, parking, all of those kinds of things. But I just list that here because it's a small amount, and I think you can really do these PFACs and others have without that funding. I'm going to kind of talk briefly about what it looked like for us. And of course, we did a lot of research to find out how best to do a PFAC, and this is well documented in the literature, but certainly some lessons learned and considerations for you all. So this is a year-long research project. The first 3 months really focused on storytelling. So with my background in the Life Story Lab, publishing on papers like What Makes a Good Story, we gave the tools for our PFAC members to share their narratives. So first, they did kind of a first pass of writing them, and then they would share them with our research team, myself, to make certain that they were honed down, that there was a clear beginning, middle, and end to their story, that there were the canonical features that are necessary for a story, the who, what, when, where, why. We also wanted to make certain that from the beginning that they had a specific lesson that they wanted to share, and that of course depends on who the audience is. So if they're trying to share their narrative to healthcare administrators, that's a different story perhaps, or if it's new incoming nurses, that's a different story. And so really making certain that we kind of call it a road, and then there's these kind of offshoot paths, and making certain that they could easily toggle across their entire road to those paths. So not only do they write them and kind of retool them when we work with our team, they are now actually sharing them in different forums. So we have various leadership groups, and for those incoming resident classes and others. So again, we are literally having the patient and caregiver in the room sharing their stories. So that was a 3-month process of making certain that they were sharing them, feeling comfortable with them, getting feedback from our team, but also the other PFAC members. And then the grant was written as such that we focused on 3 topical aims. So for 3 months each, we had a focus on, prompts of open-ended questions, tell us how we can improve in general safety and quality improvement issues. So again, utilizing their stories to elicit potential projects and initiatives. So the first one was that general identifying quality and safety opportunities. The second was their views, experiences, ways to improve supportive care, specifically palliative care. And then the final domain was a focus on their experiences with communication with nurses and providers. And again, all the prompts kind of elicit their own stories that might be embedded in their overarching entire story, but these were kind of offshoots of that. Some logistical considerations, if this is something that interests you. We really strongly advise a multi-method recruitment strategy, and so that's echoed in the literature. But what that looked like for us was we had print materials in all of our patient rooms, in the inpatient areas and such, recruiting for these PFAC members. We also, patients can consent to be contacted for future research studies, and so among those who did that, they received a letter soliciting for this Patient Family Advisory Council. And most effective is the referral from clinicians. So we actually requested among our clinicians, do you have anyone in mind that you would think that would be really good for this council? We also recommend a trained or skilled moderator, and there's lots of training for these types of things. Thankfully, with my experience working in the Life Story Lab, working in support groups, working in focus groups, I have about 10 years experience in training, so I serve as the moderator. But there, of course, are other tools and skills and strategies of how to do that well. We decided to interview our council applicants because we wanted to make certain that they had a salient experience with the UF Health and neuromedicine, but also could see beyond their own personal experience so that they could potentially identify ways to improve it. So some people are still so raw from their experiences, and some of our narratives will reflect that, I think. But some are not able to think beyond that and say, okay, well, I had a really rough situation, but I know that we could potentially improve in this way. We made certain to share our questions. So again, this is a research project, so we had to have the IRB know what we were going to ask ahead of time and kind of stick to that. But we shared those with our panelists, our council members ahead of time, so they could mull things over, think, and decide how they might want to answer these questions. It also proves very useful because some of our council members have cognitive deficits, and so for them, on the cuff, getting those questions, it doesn't work. We made certain to discuss expectations, and that's mostly about the logistics I mentioned of, they were paid, they had food, they had parking provided to them. And then I always advise having some kind of ground rules for this kind of setting. So making certain that what they're sharing, stays in that room. It's a safe space. To make certain that there isn't a stage hog taking up the whole time. So there were actually time limits on the and that was part of the job of the moderator and our research team, kind of making certain that didn't occur. Perhaps most importantly was the thematic analysis that occurred after each meeting. So we didn't actually audio record or video record these sessions. Instead, our research assistants were taking very detailed notes to identify themes that emerged across these topical aims. So after each meeting, we did that. And then as a unit of the theme, we did that. And the motivation for that was actually to feed back to our leadership. So we could say, our patients are saying, our caregivers are saying this, our data are showing that, something that resonates with them. Here's a way to address this issue. And so we've done that and come up with many projects, as we'll soon discuss. Also, equally important is this idea of closed loop communication. So we shared with the PFAC members what we're doing to address their issues. And we share that with the staff in the clinic and the residents and the physicians. Here's what your patients and caregivers are saying are opportunities for improvement, and this is what our team is doing to address that. So that closed loop communication has proven very effective. So I'm going to transition now and talking about some of our specific narratives that were elicited from our Patient Family Advisory Council and the work that is rooted in these narratives. When I was discharged from Shands Hospital, I had 9 prescription medications. That was the beginning of my learning about being overwhelmed. My father had to make a spreadsheet to make sure I was taking my medicines during the day. The amount of information from the discharge nurse totally overwhelmed me. It was months later that I would go through the information packet and discover sheets for the first time. Things had to be written down for me multiple times and posted. I could only do one thing at a time, literally process only one thing. So this is a narrative from a patient who had a rare cerebellar stroke. And it's not an uncommon experience. We recognize that our patients are very overwhelmed dealing with complex neurological and neurosurgical interventions, and we need to do a better job with the discharge process. Our team actually addressed this need several ways, but 2 are represented here. First, creating a clear checklist for what to do at the discharge. So there's a lot of science to say these factors need to be covered when a patient is discharged. Make certain that you're communicating about medications, that the meds actually reach the bed, that they know who to contact if there's an issue at home. So we actually put this into the electronic health record as a checklist for our providers to make certain that they're doing these behaviors. What's more, not in a separate issue or a complementary issue to the actual action of checklists, we have secret shoppers going around and making certain that behaviorally the providers are actually doing these activities. Related is this idea of having a patient handbook. So we have two separate ones, one for our neurosurgical patients, and mostly those are who have planned surgeries or elective neurosurgical procedures. This doesn't, of course, people who have emergency neurosurgical procedures will get a book, but just not initially. And then we have a separate one for our neurological patients who have chronic neurological conditions. And it really explains what it's like to be a patient at UF Health, either neurosurgical or neurology. Who are the type of doctors you'll see? What does your trajectory look like? It's also interactive so that your care team actually will list the medications in a booklet, and there's notes section where both caregivers, patients, and the care team can write notes. It's kind of a lofty folder, and there's a space in which you can put other papers and things. So the idea is to have patients carry, that's their thing, rather than stuffing their papers in their purse when they're leaving. This is where they should hold all of their information. So another narrative highlighted the importance of improved teaching in healthcare. Only later we would learn that he had continued taking steroids for far longer than intended, resulting in rapid weight gain. The surgeon wrote too many refills, and I assumed he was supposed to exhaust the prescription. My mistake. So again, the efforts that we just talked about really also speak to this, but specifically we also did interventions to address this issue. There's a program called EMI, and it is an interactive patient education system. It can be accessed on smart devices, personal computers. It has both print and video options for describing different diagnoses, procedures, expectations during hospitalizations. And our institution had it as in a pilot format. So we brought to light that this was available to our providers, gave them training on how to use it, created clear systems for referring patients to these modules, because we want to make sure that they have the clear education that they need. In addition, we created a protocol for teachback. So teachback is a method in which we ensure clinicians are talking to our patients and caregivers in a way that he or she understands. So it's not a test of does the patient and caregiver understand. It's a test of whether the clinician explained things in a way that's meaningful to the patient and caregiver. And there are clear domains associated with teachback, so body language is really important, empathic responding is very important, and then of course there's domains like focusing clearly on medication, like this caregiver illustrated in the previous narrative. She was unclear, talking specifically about what to do when you leave the hospital. Also, who to contact when you have a problem, so that the knee-jerk reaction isn't just to go to the emergency room. Instead, call this number, we'll get you into our clinics if it's during regular office hours. So those are the key factors that are part of the teachback protocol. And we have these print materials available highlighting to patients and caregivers, your doc and clinicians should be doing teachback, ask them about it. We also have those secret shoppers testing and doing a checklist to see whether this was done, and then give that feedback loop back to the clinicians so that they can know how to improve their care. This narrative brought to light the opportunity for improved assessment of mental health. One of the best things that occurred during my hospital stay were the discussions I had with the hospital psychologist and learning that the emotions that I experienced were normal. And the acknowledgement of those feelings was a very restorative process for me. I'm not a feelings kind of person. As an engineer, we were trained to be analytical, data-oriented, so this was very different. Acknowledging fear and other feelings is a hard thing to do, but necessary for a different part of the healing process. And although this patient actually wasn't experiencing abnormal mental health concerns, we realized after hearing this and others that we didn't have a clear systematic way of assessing at all entry points our patients' current levels of cognition and mood. So kind of varyingly, there is ways of assessing that, but not across the board. And so it's not so surprising that this would be a challenge, but what we did was identify what measures would all of our clinicians agree to use in terms of cognitive assessment and mood assessment. That was is a challenge in and of itself. But then once that's agreed, automate it into the electronic health system so that at entry points, at the first initial encounter we have with the patient, we are assessing their cognitive functioning, we are assessing their levels of anxiety and depression, because our patients then could re-enter the system, and often, declines in mental health is actually expected as part of some neurological or neurosurgical interventions. But if we have no idea where they are to begin with, how do we know how to help them over time? Of course, we always know that we can improve empathy in healthcare, and I surely learned that the hard way. But I think this narrative also illustrates that. A doctor swung back the curtain. His face was neutral, as he told us the scan had revealed a mass in my husband's brain. He would be admitted to the hospital immediately. It's a bad cancer. You have 1, maybe 2 years if you're lucky.
And what would you like for lunch today?
So you also kind of got the reaction that I did when I read this, and clearly there's an opportunity for teaching our providers how to communicate in a more empathic way, especially in sharing these kinds of news. With these types of narratives and other data, we look at our patient satisfaction data, our patients' perceptions of communication with their providers, both nurses and physicians, and we convince our leaders to consider training of empathy for our providers. So we have gained support for doing that. We intend to use this program called Empathetics. It's actually created by a Harvard-trained, or she's currently at Harvard, Dr. Helen Reese's work. So this will train our providers to hone their skills, so know how to communicate. First, she actually talks about the neuroscience behind empathy, so that will resonate with our clinicians, because often they're thinking, oh, Jacqueline, this is touchy-feely, and give me the science behind it. So we really want to root that in something that's meaningful to them. Second, they are offered specific skills. And then third, there's a module specific to sharing bad news. And so next year, the plan is to roll this out to all of the learners, well, I call them learners, clinicians in neuromedicine. So I think we really need to do a better job in healthcare instead of asking, what's the matter with you? You got a sore throat? What's the matter with you? You're having headaches, to what's the matter? What matters to you? And this actually is an entire movement in healthcare right now. It actually spawned from one line in a manuscript where a provider said that. And so this narrative, I believe this provider really was focusing on what matters to the patient, but we know that not all of our providers do that. He said, I'm sorry to let you know you have a relapsing, remitting multiple sclerosis, an autoimmune disease that affects your central nervous system, and we need to get you on a special lifetime MS medication as soon as possible. Often others can't see the issues you have with this illness as it goes and comes hourly, daily, or throughout your life. I'll never be able to test the different things you feel, but I believe you. So this, I know from this patient, that her provider really was focused on what matters to her, but not often that is the case. Our team created a campaign, What Matters to You, and actually in that book that I referenced before, the patient handbook, there's actually a space in which the patient and their caregiver can write what matters to them. It's kind of a spoke diagram. So in the center is what matters to you, and then offshooting might be, if they're getting a complex spine surgery, I want to walk my daughter down the aisle, or I'm needle phobic. Please know that. So we have some print materials, again, highlighting these efforts, and then an actual activities. So this is being piloted in some of our offices. So these are laminated index type cards on an O-ring type of thing. And we ask our patients and caregivers to identify what matters to them outside of their clinical diagnosis. So sometimes our providers are frustrated, oh, just go get your meds, you'll be fine. Well, doc, I can't afford my meds. So if there was a mechanism for saying, what matters to me is my financial situation, and let's talk about that in addition to the symptoms I'm experiencing, it kind of shifts the focus into what's the matter with you to what matters to you. I think our doctors and clinicians do a really great job of helping others, but this narrative highlighted perhaps that we can do it in a different capacity. I've learned that sometimes the life paths you don't choose can still lead to blessings and opportunities. Having MS opened the doors for me that I would not have been able to do had I been working full time. It has given me more time to volunteer at our church, and I've gone on to encourage others in multiple ways through my classes my husband and I have helped facilitate now for years annually. Through the MS Frogs support group, I've made many new friends. It's sometimes not only good for you, but you may be the perfect person to help someone. So although this patient was talking specifically about her support group, what we recognize is that we could create systems where we're pairing patients to help others. Many patients are grateful and they want to give back. We actually got state approval to create a course. And Nicole Morgan is in the audience. She actually worked on this project. So in this project, pre-health students will enroll in a special topics course. And so they will actually get paired with a neuromedicine patient. In the first iteration, the pilot format will be MS patients. And so they will become buddies. And the pre-health student will be charged with meeting the patient on a regular basis. And then they'll also go through special curricula that are focused on how to communicate empathically and aspects like that. So not only are those emotional and very sensitive topics we mentioned before, but something very simple that occur within the four walls of a hospital need improvement, and this narrative speaks to that. I had to pee. I couldn't find the bathroom and broke down crying in the middle of a busy hall. Someone walked by, did a double take, and helped me find the restroom, which had been 10 feet from where I stopped. So I think this is a reminder that our patients, their caregivers, may have never entered our health system before. It's confusing. Many of them come from outside of Gainesville. They don't know where to park. They don't know where their clinic is. Now they're charged with going to 4 or 5 other, services. And yes, there's a map, but when you just got bad news of your husband having a brain tumor, you can't even think, So to address that need, our team actually created a program called Wayfinding, a navigation program. So in our clinics, our undergraduate and NICAP interns are available to guide our patients and caregivers to wherever they need to go. So if they're in clinic and now they have to go to the pharmacy or the lab, or they just want to get a hamburger or go back to their car, they, instead of saying, Mrs. Smith, take a right and a left, you'll find it there, they take them there. If they want them to wait for them while they're getting their procedure done, they will. There's other mechanisms for linking them with a wayfinder. So there's a telephone line that when patients are entering the system, they are told about the service, and they can phone or text when they enter the system to say, hey, I'm here, I'm at Valet, or I'm at East Garage, I'm at West Garage. And so they arrive with their bright orange wayfinding shirt, and they take Mrs. Smith to wherever she needs to go. And this is a great compliment to the wonderful work that Chris Cassisi and her team has done. This is a new way of metro-based mapping system of the institution. And currently this is very intuitive and people love it, but it's only on the ground or the main floor. And so, it still remains confusing for many of our patients. And finally, a narrative that's pretty, I'm going to actually look at it doesn't show. Okay. So I had to call my supervisor to tell her my husband had been diagnosed with a terminal cancer. In the following weeks, I would try to work part-time. It didn't work out. He got depressed and I got severely overloaded. When I was at work, I had to do my normal duties, answer inquiries from concerned coworkers, and navigate an HR landscape, both foreign and inscrutable. At home, I managed my husband's medications, coordinated with his doctors and family, worked with his employers, HR department, applied for Social Security disability, made sure we both ate, cared for our dogs, cat, and chickens. I can't remember what she says in the end, but basically she couldn't do it all. This is the experience of many of our caregivers and many of the patients. And although there are community support groups referenced even in one of those other narratives, the MS Frogs group, we recognize specific to brain tumor patients and their caregivers, there isn't that program. And so next semester, our team has created a support group program called SEEK, Support, Education, Empathy, and Knowledge. It will start specifically in neuromedicine, brain tumor patients and caregivers initially. The hope is to eventually have more than just the focus on brain tumor patients, either expanded or just separate support groups. There's an education component. So what we recognize in working with, we have some of our PFAC members end up being champions in our project. So the MS Buddy program, actually one of our MS patients is the champion for that. One of our, for this support group, one of the caregivers for a patient with brain tumors is our champion for this. So again, you really kind of liaise and get the real life perspectives of these patients and caregivers involved in these projects. And what we learned was that there needs to be an educational component both for the patient and caregiver. And so there are topics that we've decided, things that are very instrumental and meaningful, like how to make sense of your bills, how to do therapeutic stretching, how to do other things with your new diagnosis that still offer meaning to your life. So after that education piece, the support group will actually parse, and half of the team the caregivers will be organized together and the patients will be organized together, and there will be a facilitator kind of assisting with the support services. So we are very proud and look forward to starting that. So I mentioned only a handful of the work that we're doing. We have many others. They all align with the big aims of quality, and that's listed here. Efforts focus on reducing harm, reducing variation, increasing value, transforming our culture, and of course, that perfect patient experience sits in the middle. They're all listed here, and I won't go into detail, but again, it gives you a sense of all of the efforts that we're focused on to improve the patient and safety experience. And I just want to be clear that improvement takes a village. It's due to the leadership of UF Health and our NICAP directors, our steering committee in NICAP, our quality steering committee, and others, physician directors of quality, our work group members within each of the big aims, and of course our PFAC. And these are our lovely team members of both graduate and undergraduate students who help us every day. So with that, I thank you. And what questions or comments do you have?
So I'm not a healthcare provider, but my mother has epilepsy and a mental illness. And so I'm wondering, and she would never be a good choice for a PFAC, right, because of the nature of her mental illness. So how do you make sure that the narrative of people like my mother are part of what people get? Because my mother lies, she makes up stories, right? And so how do you, and various cognitive things, strokes, whatever, can create changes in personality. People think things that aren't true, like, so how do you capture those people who will never be good model quote people,
Right.
whose stories are complicated by histories of poverty and mental illness, who love the attention they get, so create bigger stories that, like it's, epilepsy does specific things, and then mental illness on top of that can also make things hard.
Yeah.
So that seems like it's a big challenge.
Absolutely.
Because none of her stuff will be
Right.
Right. Well, I think I'm so glad that you mentioned that. So first thing that comes to mind is each person's perception is their own truth. And so getting some type of, getting her to share can be therapeutic, and there could be a little bit of wisdom that you can glean and again, it's not just taking what she says at face value necessarily, but using that to look at the other parts of our data that might, really inform it. And that's where the power of having the caregivers involved in the PFAC, because you, for example, would be a perfect member of our PFAC who could tell about your experience that your mother has had through the health system and, kind of the opportunities that you've seen to arise. So actually one of our patients, he has a very aggressive brain tumor, and he was doing quite well, and he had a relapse. And so now he feels very uncomfortable even talking at the PFAC. He still goes, but because he's having a lot of cognitive deficits, to your point, I mean, he is less involved, but it still has meaning. And when he does want to speak, I mean, that's his perception, that's his truth, and we want to be able to facilitate that. The support group too would be a perfect mechanism for, having patients like your mom's experience, share her narrative.
I was talking, you were talking about how you gauge the the emotional health of the certain patient through the database. Is there a way that you can gauge the emotional health of the caregiver as well?
Yeah, I also agree. So I think it will be an extension of the work, knowing that we have so far to go that there wasn't even a standard measure used, and then there is a body of neurologists, for example, who do this all the time, but they use paper pencil measures of doing it. It's very time intensive, and then there's no way of making certain that whatever they learn at that one time point then is easily discernible after multiple times. So you get that baseline on paper pencil, but what happens when they come back and do a secondary assessment? You have no way of knowing, tracking, trending, did it go up, down, whatever. So we're starting first there, but a lot of our team members, we actually have 2 of our grad teams on the big aims working on it, so it's actually 10 students focused on this because it's such a big issue, and that's been a topic that they're concerned with too, and it's definitely a goal of ours in the future.
Do you do any work where you're looking at the administrative side of things? Sometimes medicine seems like it's assembly line. Appointments are scheduled, every 20 minutes on the hour, 20 after, 20 up, whatever. And often there's very little consideration taken for the time of I'm not talking just normal routine medical care, which always is normal routine medical care. Mm-hmm. And I'm just wondering, the type of care I received when I was a child was so much nicer than what I get now on a personal level.
Right, yeah.
Not just because I was a child,
right,
but because of the way it was done.
Right, and how things have changed, certainly. So, not the written format of the narratives, but those monthly meetings where we're really focused on specific topics, we've gained insight into issues that you're mentioning. So our team not only focuses on those big aims, but in our transform our culture domain, that's really about infrastructure, improvement of efficiency. We even actually work with engineering students or industrial engineers to optimize processes. So in terms of, are we doing the flow in an optimal way? And so, yes.
I was wondering, when you were explaining the community group that you do take narratives from, if on that group there were any who were long-term from their surgical issue.
Yeah.
Because personally, I never thought about this until you were bringing it up. I'm a neurosurgical patient. Mm-hmm. I'm now 6 years out from my neurosurgical experience. Mm-hmm. Now I feel I can finally talk about it.
Right.
As opposed to then. Do you have long-term people on that committee or that group?
Yes. So I should have mentioned how we selected actually our patients and family members really closely match our patients that we care for. We have both short-term and long-term. Okay. One of the patients with the cerebellar stroke I mentioned, I think she's 7 years out from her neurosurgical procedure. And then, someone just had surgery last month and he came to our advisory council meeting last week. So It's kind of, but that diverse experience is what we are seeking, because we need the long-term, this patient, for example, talks about the emotional issues that her children, because they were young when her mom had this issue. And, that it's only now that she's able to talk about it. So.
Good, thank you.
How do you overcome, in your neurology, I work with substance abuse and PTSD and TBI at the VA, and the perception of when you get up the food chain, the feedback and implementing it and making changes. There's the stigma of being of a population that administration may question judgment of, or have preconceptions of how valid is this person's feedback.
Right.
How have you addressed that?
Yeah. So I think it's the triangulation of the data I mentioned before, because it's kind of new to just think of narratives as data and sharing that information and then creating initiatives or ways to address that issue. So what we do is we supplement that with data that they are very used to reviewing. So patient satisfaction data, that's all perception data. That's our patients who were in the clinics or who were discharged from the hospital telling us their experience and perception of the overall quality of their communication with their providers, of the cleanliness, of the quietness. And so that's a mandate from CMS. They, you have to get those types of surveys. So we,
Okay. So you're combining a qualitative with like a Likert scale.
Yeah.
Or like
Yeah, absolutely. And again, going back to, even some of our docs will say, well, I don't like those CAPS data, it's all perception. Well, doc, perception is one person's truth. And, CMS thinks it's okay and it's okay for us. So again, kind of a gentle reminder of, it is a nationally mandated quality metric, and here's kind of a narrative that supplements what those data are telling us.
I want to commend you on doing the MS Buddies program and the way you've done it. Just the volunteers in my program that have gone into medical school and talked about how they try to teach empathy. It's really hard to do that in a genuine way, but with the experiential component that you're doing, it just sounds really effective, especially with pre-health population. Before they go to med school and get all the textbook knowledge, just knowing being in med school.
Absolutely. Yeah. And Nicole should be commended because she's involved in that.